When a maxillary central incisor suffers a severe crown root fracture deep below the gum line, the tooth loses the structural foundation required to hold a restoration. The default industry response for a root in this condition is a complete extraction, discarding the native tissue entirely to replace it with a synthetic titanium implant. Crown lengthening surgery permanently cuts away irreplaceable crustal bone to expose healthy structure, leaving dark interproximal triangles. Orthodontic extrusion slowly pulls the root outward, but frequently drags gingival fibers coronally, requiring additional corrective surgery and carrying a high relapse risk. Eradicating healthy crustal bone or surrendering the native periodontal ligament to place a titanium screw accepts a permanent biological downgrade when a direct structural workaround is available. Surgical extrusion bypasses these complications. The technique involves luxating the remaining root and partially extracting it coronally to expose healthy dentin above the tissue level. The predictability of this protocol is backed by extensive clinical data. From his practice in Tehran, Dr. Valor Saif compiled the world's largest dataset, tracking over 200 surgical extrusion cases with rigorous follow-ups lasting up to 7 years. The objective of moving this root is to manufacture a specific restorative geometry known as ferrule. A viable ferrule requires a continuous collar of healthy supragingival tooth structure. The dentin must measure at least 2 millimeters in vertical height and maintain a minimum of 1 millimeter in horizontal thickness to prevent the final restoration from wedging and splitting the root. During surgical extrusion, the clinician deliberately slides the root 2 to 4 millimeters coronally. The surrounding alveolar bone and gingival architecture remain static and untouched. Surgical extrusion is a deliberate, mathematically precise method to manufacture ideal biomechanical ferrule from a compromised root, preserving the native biology without sacrificing the surrounding bone. Generating 360 degrees of ferrule is the clinical ideal, but analyzing how maxillary anterior teeth absorb force in a standard Class I or Class II occlusion reveals a precise mechanical hierarchy. During mastication, lower incisors strike the back of the upper teeth, driving the maxillary crown in a buccal direction. Because the crown is pushed outward, the palatal root wall absorbs massive tension, acting as the primary anchor to keep the crown attached. In clinical reality, severe crown root fractures do not shear in perfectly horizontal, symmetrical lines. They leave behind jagged, uneven topography. A typical presentation might yield 4 millimeters of thick, healthy tooth structure on the buccal side, but 0 millimeters of structure remaining on the palatal side. Without palatal ferrule to resist outward forces, an upper incisor restoration risks catastrophic failure, regardless of the buccal wall's height. Raw surface area is secondary to geometry. The location of the ferrule relative to the load vector dictates whether the final crown survives. When an asymmetric fracture leaves a patient with no palatal ferrule, surgical extrusion allows for a direct manipulation of the root's geometry. The root is extracted slightly from the socket, then visually inspected under magnification to ensure no microscopic cracks propagate down the dentin. To solve the mechanical deficit, the clinician physically twists the root exactly 180 degrees before seating it back into the socket. The thick buccal wall is now positioned on the palatal side. Subjecting the periodontal ligament to complete inversion raises questions regarding tissue necrosis, yet the PDL is biologically agnostic to orientation. The healing and re-anchoring mechanisms function identically, seamlessly integrating the twisted root back into the alveolar bone. The biology quietly accepts the new position, while the physics of the tooth undergo a significant upgrade. The thickest portion of the dentin now sits exactly where the occlusal load is heaviest. By utilizing a 180-degree physical rotation, a structurally deficient root is transformed into a geometrically strong anchor for a maxillary incisor. This mechanical manipulation relies on strict anatomical boundaries. Surgical extrusion is isolated exclusively to single-rooted teeth or multi-rooted bicuspids that have been cleanly hemisected. The root morphology dictates surgical viability. It must be highly conical, tapering smoothly toward the apex. If the root exhibits severe curvature or bulbous anatomy, atraumatic rotation is impossible. The irregular anatomy binds against the alveolar wall, causing root fracture. The final geometric requirement is calculated through the crown-to-root ratio. Pulling a root out of the bone inherently reduces its anchorage. To remain viable long-term, the embedded root length must equal or exceed the final clinical crown length, maintaining at least a 1-to-1 ratio after coronal repositioning. Adhering to these strict anatomical parameters ensures the root can be mobilized without expanding the buccal or lingual plates, maintaining the intact socket required for predictable tissue healing. Once the root is correctly positioned, the clinician faces an immediate logistical hurdle. Securing the mobile tooth requires bonding composite resin, a material that fails in the presence of blood or saliva. Dr. Seif's protocol utilizes a strict 5-minute rule. Instead of fighting bleeding with pressure, the clinician stops and waits. Giving the natural coagulation cascade exactly 5 minutes halts blood flow. Gentle irrigation then reveals a dry, bondable dentin surface. To secure the root, the clinician applies small tags of flowable composite resin, bridging the extruded dentin to the adjacent stable teeth. Utilizing heavy, rigid wire splints or bulky acrylic provisional crowns is strictly avoided, as excess material severely limits cleansability and disrupts gingival healing. Flowable composite creates a semi-rigid fixation. This is biologically essential. The root requires slight micromobility within the soffit to prevent the bone from fusing directly to the tooth, a failure condition known as ankylosis. Allowing natural coagulation to clear the field and enforcing semi-rigid micromobility creates the exact environmental conditions required for the severed PDL fibers to reattach securely to the cementum. The flowable composite splint acts as a temporary scaffold, remaining in place for exactly 2 to 3 weeks while the initial soft tissue healing occurs. When the patient returns and the clinician removes the composite, the extruded root will likely exhibit slight clinical mobility. While mobility usually signals failure in restorative dentistry, here it is a precise biological marker of success. It confirms the PDL is active and responding to mechanical stimulation, rather than locked into ankylosis. Because the tooth is still stabilizing, endodontic therapy on the necrotic nerve canal is strictly delayed until week 4. To execute a sterile root canal, the tooth must withstand the compressive force of a metal rubber dam clamp. Attempting this isolation too early applies shearing force directly to the healing tissue. Delaying the endodontic access until the 4th week protects the fragile reattachment of the periodontal fibers, ensuring the root is fully anchored before it is subjected to heavy mechanical torque. With the root stable and the canal disinfected, the final restorative phase addresses the severely compromised internal dentin core. While adhesive buildups have their place, the extensive structural loss in these fracture cases heavily favors the use of traditional cast metal posts and cores. When the remaining dentin walls are paper-thin, maximizing internal rigidity is vital. The exact custom fit of a cast post distributes occlusal forces evenly down the root, neutralizing the wedging effect that causes prefabricated posts to split the tooth. Anchored to this solid core, the final ceramic crown seats cleanly against an intact native gingival zenith. The survival of a severely fractured tooth does not require expensive materials or cutting-edge digital integrations. It requires an exact understanding of physical loads and healing timelines. Extracting a root slightly and waiting for the tissue to adapt proves that manipulating native biology will consistently outperform the surgical integration of synthetic titanium as long as the mechanical laws of Ferrul are strictly respected. By diagnosing the force vectors, reverse engineering the restorative geometry, and protecting the periodontal ligament, the clinician saves the tooth while maintaining the patient's native periodontium for life.